Good morning. Thank you for joining us today for the November meeting of the Indiana Commission to Combat Drug Abuse. I'm Doug Huntsinger, the Executive Director for Drug Prevention, Treatment, and Enforcement, and Chairman of the Commission. Let's get right to business. Seeing that we have a quorum of members present, do I have a motion to approve the minutes? Jake Sipe. Perfect. All in favor, raise your hand. Opposed, same sign. Perfect. Thank you. The minutes have been approved. Before we dive into today's presentations, I want to share some updates that have happened since the last time we met in August. Available today on the Next Level Recovery website, you can find the updated version of the 2020 progress report. This 6-page document highlights the steps we've taken statewide under Governor Holcomb's leadership and reflects the change in the data since August. An electronic copy of the report will be emailed to each member of the commission following the meeting. And it's clear from the progress we've made on this front that combating the drug epidemic continues to be one of Governor Holcomb's top priorities. It may feel like COVID-19 has tried everything in its power to work against us at times, but we've made tremendous strides just this year towards ensuring individuals with substance use disorder have access to the resources they need. When the state saw a rise in naloxone administrations by EMS, we responded, partnering with Overdose Lifeline, committing to distribute 25,000 doses of naloxone to anyone who requested it. Since the launch of this partnership on June 1st, Overdose Lifeline has fulfilled more than 13,000 requests for naloxone statewide. And just this week, the Indiana Department of Correction announced that it has partnered with Overdose Lifeline and the Division of Mental Health and Addiction to provide naloxone kits to offenders upon release from a DOC facility. Also this fall, DMHA introduced a series of pilot programs designed to increase access to mental health care for inmates in county jails. The pilot program will focus on individuals found incompetent to stand trial who are awaiting placement in state psychiatric hospital network. DMHA's pilot programs will work with a variety of partners to provide these services in 3 new different settings: jails, the community, and private inpatient psychiatric settings. On the prevention front, our state agencies have been hard at work educating Hoosiers of all ages about the risk of substance abuse. On October 24th, the Indiana State Police Professional Licensing Agency, the Board of Pharmacy, partnered with the DEA to collect more than 39,000 pounds of unwanted and expired medication as part of National Drug Take-Back Day. Notice a common theme in the initiatives I've shared so far. Every initiative has involved multiple agencies working together to make the idea a reality. I thought we had good cooperation prior to this year, but every day I'm impressed with the level of collaboration between our agencies. Over the course of this morning, you'll hear from agency leaders and community partners who've taken critical steps to do their part in the fight against the drug epidemic. Now, I'd like to introduce to the Commission John Lee. John is a peer recovery coach here in Indianapolis and will celebrate 4 years in recovery this March. John is a great example of how our programs are working, and he's using his experience to give back to others. John?
Thank you, Doug. I'm a little nervous, but grateful to be here. Thank you guys for letting me speak. I'm going to get started so I can hurry up and get my part out the way. I think we're getting feedback. County. I just wanted to share a quick little bit of my story. So my family was a great family. The first thing I could think of that maybe affected me mentally was probably a divorce that my parents had when they were young, or when I was young. And I grew up with my father, who is a military man, 30-year colonel. So I want to say thank you to him and all our veterans, as this is, Veteran Week. And The first thing that really after that, well, the next thing really after that that I can think that really was a little bit of trauma towards me was him getting sent off to Iraq. I was in middle school. I didn't really know how to handle it. And shortly after was when I started experimenting socially with alcohol and smoking a little bit of marijuana. And but I didn't think it affected me that much. And moving on into high school, I played sports, and sports slowly started to become less important to me, and partying became a little bit more important to me. Um, Followed by an injury and the experimentation of pain pills. I found out a good way to cope and something that felt good to me. And so remembering that feeling, that became my go-to when bad things would happen. And still at that point, it wasn't completely affecting my life. It was a social thing to me. And senior year, I ended up trying heroin for the first time. And my story isn't what the stories used to be, where this was only in bad neighborhoods and bad areas. I grew up in a great small rural community, family, not poverty stricken. My parents worked comfortably, and so it just is showing that even in these areas, this stuff showed up, and like I said, I loved it, and but still, it didn't affect my life like that up until college started. The first week of college, I lost my best friend. He committed suicide, and that was the first serious traumatic thing that I dealt with, and I didn't know how to cope with, and I didn't know how to get help for mental health at that point. And the only thing I knew to do was use, because I knew that was what made me feel better. And I didn't want to be in college at that point. Like I said, I wasn't getting help, so the only thing I knew to do was go home and be around friends and to cope the way I knew to cope, which was using. So after my first semester, I dropped out of college and went home and wasted everything I had on using. This continued until my first arrest and first run in with the justice system. And after that, I got out, experienced my first bit of recovery, which was great, but I still never addressed my mental health issues. I went to prison for the first time and got out, did great for a while, and I experienced a reoccurrence after almost a couple years of sobriety, and I didn't know why. But I think back on it, I was losing more friends, more people I knew were dying, issues that I'd never addressed. So I went back to what I knew, and that was using. That was how I coped. That was my addressing mental issues. So until I ran into the justice system again and went back to DOC again, um, it took me until this run in, and I met an individual behind the walls who helped me immensely and really introduced me to a different way. And I know a lot of you guys are familiar with him. His name is Brandon George. He helped me immensely. And following doing his treatment program and getting out, I met with a peer recovery coach at Integrated Wellness and coupled that up with a physician to address my mental health issues that I'd never addressed previously. And changer, it really was, because I started dealing with a lot of the anxiety and depression and trauma issues that I experienced growing up, and the more trauma that people can say it doesn't affect them, but going to prison, you see stuff that it ultimately affects you because it's stuff that you don't leave behind. And I want that to be something that hopefully we can address and focus on, because it's great. I love that we're helping people behind the wall and helping them on their reentry. But if we're not helping address the mental health issues, then what are they going to go back to? They're going to go back to what they know. So I want to make sure that we're providing the harm reduction tactics like Narcan, but also addressing that mental health so they can continue to move forward and be successful. And yeah, so eventually really wanted to give back to the recovery community. This was something that, after meeting Brandon and seeing everything he had been doing and continues to do, something I wanted to get involved with. I really wanted to be a part of that. So I, did my training to get my credential in recovery coaching, and got my certification for addiction peer recovery coaching too. And yeah, now I get to work for Mental Health America of Indiana for 2 different organizations, helping give back, and it's it's fulfilling. I really really love it, and it's something that I want to pass on to everybody. I want everybody to be aware that there is light at the end of the tunnel and that you can change. We just have to address a little bit of stigma there, one with people behind the wall and people on the streets, and then help people that do the same stuff. I was lucky that, like I said, I have a family that could give me insurance and pay for a lot of stuff, like a genome mind test that could help me figure out the exact medicine that I needed to help my anxiety and depression. And yeah, I want to be able to extend the hand out and hope that we can help more people and do this for as many people as possible, because I want to see everyone. So I'm gonna go ahead and get out the way, because I know it was supposed to be short, but I want to thank everybody from the bottom of my heart for letting me speak today and share a little bit of my story. And I hope that we can continue to help out and help with the stigma and the problem that's going on today, because like I said, there is light if we do what we can and help people. So thank you, guys.
Thank you, John, and thank you for sharing, and thank you for the work you're doing as a peer recovery coach. Your story is really compelling and reminds us all of why we do the work that we do. If you all recall, I announced in August that we'd be rolling out our new data page on the Next Level Recovery website. And so here's Josie Fasselt from the Management Performance Hub to show us the new data page.
Good morning, everyone. My name is Josie Fasselt, and I am the Senior Director of Engagement and Analytics for Health and Human Services at the Management Performance Hub. I'm here this morning representing all of our state agency partners that are involved in the state's Drug Data Working Group, which supports the Executive Director of Drug Prevention, Treatment, and Enforcement. And for those of you who do not know, our Drug Data Working Group consists of 11 agencies and has been meeting every month for the past 4 years, discussing and reviewing state data related to drug trends and substance use disorder. Today, we're excited to announce that the Next Level Recovery dashboards have been updated on the Next Level Recovery website, and I've been invited to give you all a walkthrough of those updates. But before diving into the newest features, I thought it might be good to quickly recap what was previously available. In the past, when a user went to the data section here in the Next Level Recovery website, we had the following visuals available for them. First, we had a heat map that shows naloxone administrations happening across the state. And then second, in the Indiana by the numbers section, we had a series of dashboards that showed aggregate opioid prescription, deaths, as well as additional naloxone administration data by county. Thanks to our partners at the Indiana Department of Health, Professional Licensing Agency, Indiana State Police, Indiana Department of Correction, and Indiana Department of Homeland Security, we have redesigned the Next Level Recovery dashboards to include more up-to-date information for you. When you now go to the data page on the Next Level Recovery website, you will see several dashboards available for you to explore. Let's go through each of them to get you familiar with the content. The first dashboard focuses on the state's response to the drug epidemic by county. On this dashboard, you can select a program to see how many counties offer that particular resource in their community. For example, I can click here on the syringe exchange program selection. And here I see that there are 9 counties shaded in blue that offer a syringe exchange program. I also see here the program overview as well as additional program contact information that might be relevant for me in case I would want to learn more. The next dashboard provides information on hospital discharges in Indiana, where a user can view hospitalizations and emergency department visits for drug-specific events. For example, I have selected 2019 heroin emergency department visits in this dashboard, which shows me as the user the count of emergency department visits that occurred during that year for the entire state, as well as the age-adjusted rate. You can select a county to learn more about that county's demographics, as well as their annual percent change from the previous year. And you could also view that county's trends occurring over time, by year, by quarter, or by month. The third dashboard shows data for individuals who died of a drug-related death in Indiana. Here in this dashboard, you can select the year as well as type of drug death that you want to analyze. For example, I will select 2019 synthetic opioid drug deaths in my filters. And here I can see the total count of synthetic opioid deaths for the state and by county. I can also see the age-adjusted rate, as well as the percent changes from the previous year. And I can also view trends that occurred over time, again by year, by quarter, and by month. All three of these dashboards, meaning the county response, hospital discharges, and deaths dashboards, you will also see from the Indiana Department of Health's overdose prevention website. We worked together really hard over the past months to make sure that users had a seamless user experience between the overdose prevention website from the Indiana Department of Health, as well as the Next Level Recovery website. The next dashboard shows naloxone administrations for the state, by county, and over time. This dashboard is extremely similar to what has been provided in the past on the Next Level Recovery website, just with a few additional features. First, a user can select to see the rate of naloxone administrations over time here in the line chart. Also, we included an additional button where the user can view the naloxone heat map within this dashboard as well. Next, a user can view opioid prescription data, both for the state and by county. Here, a user can select to view prescriptions or dispensations by year, drug class, or by the county of the patient, pharmacy, or practitioner. For example, here I have selected to view opioid analgesic prescriptions in 2020. I can view this information for the entire state and by county, by payment type, demographics, and I can compare a selection I have made with what the state's overall count is as well. The next dashboard shows drug arrest data. Here, a user can filter by individuals arrested, total arrests or offenses, as well as the stage of the offense, the year, and to look at the data by count or by rate. For example, I will select individuals arrested and their most recent arrest or disposition for 2020, and I will take a look at the rates per 10,000 county residents. When I do that, it filters the dashboard by state and by county for me, as well as additional offense subcategories. For example, here I can view the number of methamphetamine offenses for dealing, manufacturing, or possession, and I can see the total number of individuals that were arrested during that year. I can also view arrests that occurred over time, as well as additional demographic information that might be important for me to look at. The last dashboard is the rearrest dashboard, which looks at individuals who left incarceration from a state prison but were then rearrested for drug-related offenses. In this dashboard, a user can filter by release type, for example, community transition program, discharge, parole, or probation, as well as the rearrest offense category, such as offenses for drugs, traffic, or violence. For example, here I can select on parole as a filter and analyze the number of individuals released over time and then rearrested for drug-related offenses. I can look at that by state for a particular county, and when I hover over the county, I can see more demographic information that might be useful for me. There's also a section to learn more about the data in case you're interested in learning more details about the specific sources, providing entities, data refreshes, and date ranges for when we pulled the data, and other important caveats that we were considering in the making of this dashboard. We hope that these dashboards will be useful tools for all of you and for our partners. At MPH, our mission is data to the people, because we believe in our bones that empowering our decision makers and the public with data to help inform their decisions is vital to the growth and health of our Hoosier communities. We hope these dashboards will be useful for our partners and advocates in combating the drug epidemic here in Indiana. For any additional questions, please contact us at MPH. We'd love to hear from you. And on behalf of the Drug Data Working Group, thanks so much for giving us all the opportunity to be a part of this work.
I want to thank Josie and the team at MPH and the Drug Data Working Group, as they have all worked hard to provide transparency and accessibility to our data. I also want to thank the Department of Health. The update, showing the programs and the data on the map is based on their initial design and work. The data site is a work in progress, and it's meant to be continually evolving and expanding. So as you have a chance to look at the site, please let us know if there are opportunities to expand the data that we're presenting. Now, Michael Ross, the director of the Indiana Criminal Justice Institute's Behavioral Health Division, will introduce our next speakers.
Good morning, everyone, and thank you for allowing us some time to speak this morning. The individuals that I'm going to have speak are presenting on a program that we're really proud of. As many of you know, we funded several pilot projects, approximately $514,000 worth of pilot projects at our local coordinating council level. And Scott County will be speaking today about their project, which will be extended into 2022 because of the success. Their project was intended to strengthen communication and knowledge transfer for these really unique and important entities in our state. And with that being said, I'm going to turn it over to Lori and Bobby to present about how they've done this.
Members of the Commission, thank you so much for this opportunity to share with you today. Local coordinating councils are approved by the Indiana Commission to Combat Drug Abuse. Each of Indiana's 90 counties has an LCC that is open to the public, engaging cross-discipline stakeholders to create, implement, and evaluate their local comprehensive community plan to address substance use. In 2019, the Indiana Criminal Justice Institute's Behavioral Health and Research Division surveyed the local coordinating councils who expressed that collaboration and coordination of resources is a challenge for community-based coalitions. I am Lori Crosdell, and with my colleague Bobby Foster, will be speaking to you today about the great work happening through the Indiana Coalition Network that has not only helped our Indiana's LCCs, but has received national attention for it. Next slide. Local coordinating councils are the frontline defense against substance use. They monitor, plan, create, and carry out substance use initiatives by bringing engaged cross-sector members from schools, law enforcement, health, social services, and industry. Most LCCs fund their initiatives through the drug fines collected by their county court. As part of a statewide strategy, we created a dynamic solution that serves as a communication platform, a cache of information, an area to share files and resources, and store information for community-based coalitions and those seeking recovery supports and services. The Indiana Coalition Network, or ICN, is a digital platform and webinar series that connects community coalition members so they can take informed action on drug and alcohol use in the areas of prevention education, treatment, intervention, and recovery, and justice law enforcement. The ICN platform increases collaboration within and between 92 LCCs throughout the state of Indiana, while also connecting members to the existing statewide and national alcohol, tobacco, and other drug infrastructures and resources. The website provides interconnected subject-specific collaboration hubs so that all stakeholders can be reached with flexible, well-curated, and measured knowledge sharing. Sharing means having information and links to resources in one place, creating a knowledge base for a wide range of users, and the ability to access and share information with other statewide coalitions and recovery supports and services. This includes articles, best policies and practices, documents, websites, videos, etc., and the ability to hold online discussions around topics of interest. Next slide. This web-based platform is easy to access and navigate. It also provides tools to easily make collaborative connections and find best practices. Members are able to access resources such as data, documents, webinars, podcasts, and more. It also allows members to connect to the existing recovery infrastructure. And it is a warehouse of historical data and resources. When people join or leave, their organizations have reduced downtime looking for files, communication. And it's a free resource. There's an information exchange for members where they can share documents, links, and resources. They can have conversations where they can ask and answer questions. And quickly, there are groups where members can have conversations with everyone or a specific group. And there's a Member Connect section where they can find other LCCs in the state and their sector representatives. Next slide.
The Indiana Criminal Justice Institute is a member of the Indiana Commission to Combat Drug Abuse and is charged with supporting efforts to create drug-free, recovery-focused communities. The ICJI responded to the needs of its local coordinating councils and pulled together a team to collaborate and create the Indiana Coalition Network through the Drug-Free Community Pilot Grant. Financial and administrative support, ICJI provides research and direction. The Indiana Recovery Network and Indiana Addictions Issue Coalition has been the guide and resource for the development of the ICN website and monthly webinars. Solutionize is the website developer and host, providing continuous updates and improvements, in addition to educating users on site features and navigation. The Scott County Partnership is the fiscal and administrative agency for this ICN pilot project. CEASE, the Coalition to Eliminate the Abuse of Substances, is the Scott County Local Coordinating Council. We have facilitated website and webinar development, curated the exchange of information, engaged LCC membership, and monitored and promoted the platform. Next slide, please. Encourages oral communication, quicker responses, more accurate follow-up reports, and more creative activities to address substance use. LCCs are following through on their desire to connect. For within 2 months of the site launch, 62% of coalition registration goal was met. Currently, 95% has been achieved. Nearly 100 resources have been uploaded to the public and private sites. This is in addition to the information shared through the news, events, conversations, and groups. We're seeing significant growth in the development of collaborative groups. 11 private and 2 open to all subject-specific collaboration groups were created by members. Attendance at the monthly webinars continues to grow, reaching more counties and people outside of the LCC network, which is an opportunity for coalitions to build their membership and community engagement. The average attendance over 4 webinars is 28 people from 21 different counties.
Hang on one second. And our recent conference proposal submission entitled Developing a Statewide Platform to Strengthen Communication and Collaboration Among Community Coalitions and the Recovery Infrastructure was selected for a breakout session by the Advisory Board of the National Prescription Drug Abuse and Heroin Summit in Nashville, Tennessee, April 5th through the 8th, 2021. We are so excited on earning this honor in a competitive review process. Next slide. Thank you so much today for your time, and what an honor it has been to share this with you. Thank you.
Well, thank you, Lori and Bobby, and I'm looking forward to tracking the progress of this project. As all of you know, local coalitions have been a really important strategy of ours, and I'm looking forward to seeing how we can better incorporate this tool into our larger effort. So thank you for your time today. Next, we have Katie Hokinson, who is the Director of Trauma and Injury at the Department of Health, to provide an update on their work.
Good morning, Commission members. My name's Katie Hokinson. I'm the Director of Trauma and Injury Prevention at the Indiana Department of Health. And today I'm going to be sharing updates with you on how the State Department of Health is combating the opioid epidemic. ECHO stands for Extension for Community Healthcare Outcomes and began in New Mexico in response to a hepatitis C outbreak and a shortage of specialists to treat hepatitis C. ECHO brings together specialists and community providers virtually to learn from one another through a hub and spoke model. The hub is made up of subject matter experts who then train and support local practitioners. The format of the ECHO sessions are pretty standard. They are held virtually, and in our case, which I'm going to talk more about here in a minute, so hang tight, our sessions are once per month. There are introductions and then a 20-minute presentation from a hub team expert with time for Q&A. A local team member then presents a case that they may be having challenges with and want to seek the advice of other spoke teams and hub experts. A traditional ECHO is a clinical model where the hub experts are healthcare specialists in a particular area. The spoke team is also made up of healthcare professionals who are seeking to expand their knowledge about a specific treatment area. And the case presentation is almost always focused on a specific patient. In the NCARES ECHO model, we are using a community focus. This means that the hub team is made up of a diverse group of experts from various fields and backgrounds who have demonstrated success in working in substance use and overdose prevention, intervention, and/or treatment. The spoke teams are comprised of community leaders from each of the 16 counties, And the case presentation is not focused on a specific patient, but about a much broader problem that communities are facing in regards to substance use and or overdose prevention, intervention, or treatment. The NCARES ECHO is one of the funded projects I'm here to share with you today through the Overdose Data to Action grant from the CDC that falls under the key strategy of integrating state and local prevention efforts. The name of this grant says it all, Overdose Data to Action. For this particular project, this is a partnership between the department and the IU Fairbanks School of Public Health. In the fall of 2019, we released a grant opportunity announcement to communities across the state. Due to COVID, some of the progress has been delayed on this program, so we recently released a request for proposals for additional funding to our current counties for year 2 of the grant. We are also modifying our original year 1 plan to account for impacts of the COVID-19 pandemic. Today, I want to give you a little bit of background on Project ECHO and what we are doing in Indiana that is unique. These are the locations of the 16 communities funded for this particular NCARES ECHO project. These counties were chosen by their application and their level of burden due to the drug epidemic. These are some screenshots from our most recent ECHO session. The Hub team subject matter expert on the left, Free to Be Mom, gave a presentation, and then the image on the right is one of our counties presenting their case in the picture. As part of this funding opportunity, we really want to fund local prevention efforts. The request for proposal utilizes the ECHO model that the grantees participate in. Each community was able to propose projects that they wanted to implement that fall under one of the listed 4 strategies. These strategies are outlined in the Overdose Data to Action grant. The RFP provided a list of possible projects that communities could choose from, but counties could also propose their own projects. I want to highlight a couple of the counties that are finding success just in year 1, even with everything going on with COVID-19. For example, Dearborn County was awarded funding for all 4 strategies and are seeing success on all of their proposed activities. They are seeing the most notable success on strategies 3 and 4. As part of strategy 3, harm reduction and anti-stigma promotion, Dearborn County proposed an activity to embed a peer recovery coach in their court system as part of their Choices community response team. They have seen a great deal of success with this activity. They've noticed that since embedding the peer recovery coach, access to immediate referrals to care have been made possible. Additionally, they have seen an increase in focus on person-centered recovery plans by the court system officials. Under Strategy 4, additional activities, Dearborn County proposed implementation of an overdose fatality review team. I'm going to talk more about those teams here in a minute. They began recruiting for the team at the beginning of the year and had set an attendee list in March. Initially, they were unable to meet due to COVID restrictions, but have since developed a plan to meet while following health and safety guidelines and started meeting in August. Another county I want to highlight is Clark County. They were awarded funding for all 4 strategies and are seeing success on all of their proposed activities, most notably in strategies 1, 3, and 4. In strategy 1, primary prevention, Clark County activities included hiring a health educator, launching an amphetamine medical psychosocial team, and to conduct Narcan training and placement in schools. Clark County has succeeded in hiring a health educator to promote public education and awareness of substance use disorder through public events and trainings. The health educator has hosted CPR and naloxone trainings for the community, and they've also begun working with first responders to expand the Pulse Point program, an app that alerts CPR-certified individuals of nearby cardiac arrest and overdose reports. Clark County has succeeded in developing their AMP team to conduct community outreach, develop a resource framework, and collaborate with local providers. This team is made up of local hospitals and healthcare centers as well as the local OTP. The health educator has conducted Narcan training for the community, including school nurses and administration in the sessions. And currently they have 14 doses of naloxone in schools. For Strategy 3, harm reduction and anti-stigma promotion, Clark County proposed to expand their current syringe service program, initiate a series of programs to provide education on SUD and available resources, and purchase nalox boxes and connect their availability to Pulse Point, similar to the AED registration currently available in Pulse Point. One major accomplishment was that throughout COVID-19, Clark County has been able to keep their SSP open and running without any interruption to services. Clark County was able to host a program discussing the unique needs of the older populations caring for children or grandchildren with substance use disorder, as well as hosting a forum discussion on stigma prevention and compassion fatigue for the community. Clark County is currently working with local convenience stores to place community aid stations within their businesses, which would include naloxone, AEDs, and Stop the Bleed kits. All of these community aid stations are linked to the Pulse Point app. In Strategy 4, Clark County partnered with their local coroner to provide overdose data to the Department of Health. This information has been helpful in providing insights for the overdose fatality review teams. Clark County assembled an OFR team that traveled to St. Joe County to observe an OFR meeting in February, and then starting in March, they have met every month to review cases. We have a lot of counties doing amazing work, but I just wanted to highlight these two with you today, and we're going to have more information on the success of the NCARES Echo in future meetings and also available on our website. So next I'm going to talk about overdose fatality review because I know I've mentioned it a couple times now. The purpose of an OFR, overdose fatality review team, is to effectively identify system gaps and innovative community-specific overdose prevention and intervention strategies. In practice, OFRs involve a series of confidential individual death reviews by a multidisciplinary team. A death review, also referred to as a case review, examines a decedent's life cycle in terms of drug use history, comorbidity, major health events, social emotional trauma, including adverse childhood experiences, encounters with law enforcement and the criminal justice system, treatment history, and other factors, including local conditions, to facilitate a deeper understanding of the missed opportunities for prevention and intervention that may have prevented an overdose death. By conducting a series of OFRs, jurisdictions begin to see patterns of need and opportunity, not only within specific agencies, but across systems. Here's a snapshot of the Indiana Overdose Fatality Review structure that you can see on your screen. And on the map, you can see where our current 16 teams are located throughout the state. They conduct family interviews and psychological autopsies. And this team reviews both suicide and overdose deaths. They collaborate with the Fatality Review Program, including Maternal Mortality Review and Child Fatality Review, focused on youth suicides at the moment. And the Community of Practice monthly call is for all local coordinators. The overdose fatality review teams have definitely had to adapt during COVID-19, and there have been virtual presentations of OFR 101, what it is and how it works. The program has also been formulating guidance documents for teams to review and modify and discuss delivery of services during COVID-19. Case reviews have been held both virtually and in person over the summer and fall. Local teams met virtually at the beginning of COVID to develop a plan for drafted recommendations, assigning tasks, creating bereavement care packages, and writing community suicide response toolkits. As of October, 9 of the 10 new 2020 teams have been meeting, and the remaining team will begin case review in December. The Fatality Review and Prevention Program is excited because they have started to engage new additional teams already for 2021. I want to recognize the Indiana Fatality Review Program because they were selected as one of 4 BJA Mentor OFR sites for 2021. An OFR mentee experience includes a 1-hour introductory call at least 1 week before the OFR virtual site visit, 2-hour OFR observation, 1-hour post-review discussion call at least 1 week after the OFR virtual site visit, facilitated discussions with 1 or 2 OFR members as requested by the peer mentee, and feedback to the Institute for Intergovernmental Research, the BJA designated training and technical assistance provider, by both the mentor and the mentee about their experience. This is an awesome opportunity, and it's great to see Indiana serving as a leader in this capacity. The Department of Health was also chosen as a peer-to-peer site for OFR. States chosen to be peer-to-peer coordinators display a specific area of expertise within the prevention component of the Overdose Data to Action grant, including overdose fatality review teams. Indiana areas of focus include OFR establishment, navigating the coroner system, accessing data and data sharing agreements, family interviews, social autopsies, local county level teams, and OFR legislation. In 2019 and early 2020, the OFR program manager advised on the development of a national OFR database. Through the BJA Comprehensive Opioid Stimulant and Substance Abuse Program, the OFR database selected pilot sites to use and provide feedback on the standardized OFR database. St. Joseph County OFR team was awarded funding to be a pilot site. The department is a volunteer pilot site as well. Partner agencies collaborating on the database include BJA, IIR, CDC, CDC Foundation, and other veteran OFR teams. The analysis of available data allows teams to make recommendations that will prevent future overdose deaths. OFRs can serve as a powerful tool to bring communities together, systematically analyzing the response to overdose deaths and mobilizing participants to take action. Another program I want to feature that we are currently doing is called the SHIELD training. SHIELD stands for Safety and Health Integration and the Enforcement of Laws on Drugs. The department wanted to bring this training to Indiana to provide education and information, not just about substance use disorder and syringe service programs, but officer mental health awareness and occupational safety. These are some of the topics that we cover in this SHIELD training. And the first training session was held virtually in September. We were pleased to have representation from a variety of counties, both large and small. The takeaway in terms of the results is that officers changed their attitudes, beliefs, and the ways that the training was supposed to. The true effects will be more apparent when we have more responses. So for now, we are mostly reporting percent change. So that means the percent of officer respondents that shifted their post-training survey responses in the correct direction. I say direction because most questions were on a scale, like strongly agree to strongly disagree. So a shift may have been from strongly disagree to a disagree or strongly disagree to agree, which counts as a positive change if the correct answer is to agree. Our next SHIELD training will be in December, and we're going to be opening it up to a much larger pool of participants after seeing some of the initial response. So next, I want to talk about surveillance and data. In 2018, it was the first year in over 2 decades that the number of overdoses were less than the previous year. Unfortunately, in 2019, fatal overdose increased by 4.2% from 2018, and fatal overdoses due to opioids increased by 13.5% from 2018 to 2019. Opioids continue to be driving force in the increase in overdoses. There were 577 fatal opioid-related overdoses from January to June in 2019. During that same time period in 2020, there have been 816 fatal opioid overdoses, a 41.4% increase. In 2019, from January to June, there were 2,274 emergency room visits due to an opioid overdose. During that same time period in 2020, there were 3,473 ER visits, a 52% increase. And in 2019, from January to June, there were 669 hospitalizations due to an opioid overdose. And during that same period in 2020, there were 776 hospitalizations, a 16% increase. As the focus on opioid misuse has increased, there has also been an increase in stimulant use. In 2019, 268 fatal overdoses involved cocaine, and 507 fatal overdoses involved a psychostimulant, not including cocaine. The phenomenon is seen across the country as the use of meth and other stimulants are increasing. There are many theories to explain polydrug use. Some people with opioid use disorder are using meth and other stimulants to mask the effects of withdrawal in order to stop using opioids. And some believe it is safer as they are scared the opioid supply is tainted with fentanyl. Nevertheless, this shows that there's still work to do in the prevention of drug overdoses and drug misuse. The Department of Health has been distributing naloxone to local health departments for the past 4 years. The 2020 grant round had the highest number of participants to date. This was the 6th grant opportunity for local health departments. The naloxone program has been funded through state dollars and the support of FSSA. FSSA received their funding from SAMHSA through the 21st Century Cures and SOR grant. And here you can see the number of doses that we've been distributing of naloxone to our local health departments continues to increase year after year. The department is also a recipient of the First Responder Comprehensive Addiction and Recovery Act grant from SAMHSA. The grant started in 2017 and is a 5-year grant. The grant focuses on providing naloxone to rural first responders, and rural is defined by federal OMB. 49 counties are eligible for this grant. Here you can see the distribution of naloxone to our rural first responders, and the decrease in participants may be due, in fact, that the local health departments have more access to naloxone. Agencies are also able to receive doses from their local health department. COVID-19 has put a strain on first responders, and capacity could be a contributing factor. The next slide shows you kind of the breakdown of the different grantees that are receiving the naloxone for the rural first responders, the majority being fire and police. And this just shows you the distribution of naloxone by year. Some more data information. We have the behavioral risk factor survey, and what we are doing in the division is specifically funding a couple of modules to collect additional data around ACEs, adverse childhood experiences, as well as opioids. And then in 2020, we added the recovery treatment module. And then our plan for 2021 is to fund both opioid and recovery treatment. And there is information on our website if you want to go to the next slide there. This is a recent report put together by the department on the ACEs module. In 2008, the CDC developed an optional BRFSS ACE module with questions adapted from the original ACE study to collect information regarding the prevalence of ACEs and their relation to major public health concerns within each state. The ACE module is comprised of 11 questions referring to the respondents' first 18 years of life that assess 8 types of ACEs that you can see here on the screen. And Indiana's first included the ACE module in 2018. The next slide will show you that ACEs, as we know, are prevalent among our Indiana adults. A majority of respondents reported experiencing at least one ACE, and about a fourth reported experiencing 3 or more ACEs. The most common experience categories were parental separation or divorce, emotional abuse, and substance abuse in the household. The next, I want to talk briefly about our toxicology program and what we are doing in providing free toxicology testing to our 92 county coroners. So if you want to go to the next slide, I remember back in 2016, Tim George reached out to me and said, Katie, why is it taking so long for us to get the death certificates and to understand what the cause of death is? And so we started to dig into this a little bit more, and this kind of shows you the timeline. Coroners are able to collect the sample pretty quickly. Analysis takes a while, but then what happens is when that report goes back to the coroner's office, they typically have a medical examiner that's reviewing that report. And with just the increase in deaths, the reports were getting further and further down in the stack. And so that's why it was taking a period of time for us to have that final death certificate from the coroner's office. So if you go to the next slide, what we just noticed overall is that coroners have limited funding, that they maybe weren't testing all substances every single time, and that we at the Department of Health, we didn't have access to that individual county testing results. So what we did is we proposed a pilot toxicology program federally funded, and it started in August 2017. We started with initially 5 counties, and then we expanded that starting in 2018 to add an additional 8 counties. For the forensic toxicology testing program, the staff at the Department of Health reviewed multiple toxicology companies' standard testing protocols. After careful review of the different protocols, the Indiana Violent Death Reporting System data, and current drug trends, staff created an inclusive toxicology panel. The staff then consulted with multiple subject matter experts, including doctors, PhDs, county coroners, and the Poison Control Center to review the toxicology panel to ensure that the panel was comprehensive and would provide the information needed to adequately report overdose mortality data. So if you go to the next slide here, you can see the Indiana code that was passed a couple of years ago that essentially tells coroners that if they suspect a drug overdose death, that they are required to submit that sample to the toxicology lab, and that the Department of Health, we currently have federal funding that pays for that test for the department, and then that information gets reported directly to us. So if you go to the next slide, you can see that law passed in 2018, and as I mentioned, and I can't stress this enough, is that we are continuing to use federal funds to pay for these comprehensive panels. through the toxicology lab that was selected through the bid process access, and this is funded through at least August 2022. And between January and September of this year, we've already received 2,000 toxicology tests to coroners, or from coroners. Just note that, again, this is for any suspected drug overdose deaths, so this isn't meaning that these are for sure overdose deaths. It's just if they suspect anything, that we encourage them to go ahead and test. If you go to the next slide, this just talks briefly about the bid process that we went through, just because we did originally start with NMS, and then we moved to access. The great thing about this toxicology program is that it gives us the ability to respond quickly and appropriately to the drug overdose epidemics depending on complete and timely data. Wayne State is going to go through and give you a little bit more of an update on some of the results that we're seeing with this data. And the next slide, I know Josie already spent some time talking about this, is the Indiana dashboard. So I won't go into any more specifics about this, but we are excited to see the expansion of this effort. If you go to the next slide, again, this kind of just gives you an overview of our overdose data to action programs. And the next slide will show you we are really focused on collaborating at the Department of Health. We do a lot of internal collaboration between our different divisions, and you can see all of those highlighted here. Anywhere from the opt-in registry, we're an entity that provides naloxone. They have to register with the state. We oversee that and provide funding for that. We're partnering with HIV, STD, Hep C to do an MPEP echo, oral health to provide education for dentists on prescribing best practices. And if you go to the next slide, Doug talked about this, about that collaboration. We really cannot do the work that we're doing without collaboration between different state agencies, really wanting to focus on enhancing efforts that are going on and expanding things that are already found effective. The next slide will show you also some of the other local partners that we have partnered with throughout the years. We just try to meet with our partners regularly to get a handle on what's going on at the local level and what we can do to expand our efforts. So the last slide just shows you some other things that we're working on, including our partnership with Wayne State and their program evaluation. We also are working closely with the Marion County Public Health Department. And the next slide will show you the weekly email that we send out. So hopefully you get that. There's about 1,500 people that subscribe to this weekly newsletter that we send out with the goal of trying to provide the latest news and information about the opioid crisis. Thank you. And next we're going to have Brad Ray's presentation on the toxicology program.
My name is Dr. Brad Ray. I am the director of the Center for Behavioral Health and Justice and an associate professor at the School of Social Work at Wayne State University. Today I'm going to be talking about two projects that my team and I are working on with the state of Indiana. The first is this Indiana Department of Health statewide toxicology surveillance report, and the next one will be DMHA's Recovery Works program and evaluation that we're doing of that. But first, with this statewide toxicology surveillance report, I want to start with a bit of a background of where we are nationally. As you can see here, what was once an epidemic driven by prescription opioids, it has shifted largely to illicit opioids. So you can see in 2000, we see these increases. We refer to these as the waves of the overdose epidemic. So you can see that first wave around 2000, the increase in prescription opioid related deaths, shifting to heroin in wave 2, and then fentanyl in wave 3. In wave 4, what we're seeing is a co-use of illicit opioids with illicit stimulants, methamphetamine and cocaine. And so you can see on the right there, though, the substances most frequently detected in overdose deaths nationally are fentanyl, followed by illicit stimulants, then heroin, and then prescription opioids. Indiana has historically had a problem with undercounting opioid-related overdose deaths. In some years, almost half of the drug overdose deaths were coded as unspecified. So what this means is that the coroners have determined that it was a drug overdose death, and they've assigned the appropriate ICD codes for that overdose death. But there are additional codes that delineate the specific substances that are associated with that death, and in particular, whether or not opioids were involved. And so the concern was that with Indiana not accurately counting the number of opioid-related overdose deaths, that they might not be receiving the appropriate resources to address the problem in the state. We did a study in 2018 where we looked at 6 years of data just from Marion County. And over those 6 years, 58% of the overdose deaths were determined to be unspecified. And we found that 86% of that 58% had an opioid in the death, screened positive in the toxicology results. The opioids were, prescription opioids, heroin, and fentanyl, but just illustrating this undercounting problem in Indiana. So in 2018, the Indiana Code was established that required toxicology screenings on all suspected overdose cases. And so what we've done is enter into a partnership with the Management Performance Hub to link those toxicology results that come in to those ICD codes and to essentially replicate that study in near real time, looking across counties to see where there might be variability in that undercounting of opioid-related overdose deaths. So that's really where our analysis at this time is focused. And so I'll say, MPH is able to really seamlessly bring in data from the vendors. So even as the vendors in Indiana have changed, the labs have changed from NMS to Access, they've been able to seamlessly bring that information in every quarter and link it up to the ICD codes for these analyses. Currently, we're looking at data from January 1st, 2018 through April 4th of 2020. 90 out of 92 counties have submitted a toxicology report. I will say the 2 counties that haven't, Benton and Ohio County, very small, I believe around 9,000 and 6,000 respectively. So it's possible they just have not had any events. But this has, over this time period, resulted in 3,585 toxicology reports, of which a little less than half, you can see, are associated with that ICD code of X40 through X44 of an accidental drug overdose death. So it's that 1,554 overdose deaths that we're really focusing on for this analysis here. And you can see the map on the right there is just illustrating the frequency of where these events occurred. It's not adjusted for population, but just to show where we're seeing these events coming in from across the state. So you can see within those fatal overdose deaths, you can see the substances here that were most frequently detected. We created a measure of just any opioid, so 85% of the deaths, the toxicology results contained any opioid. So this could have been fentanyl, heroin, prescription opioids. But the most commonly detected substance by and large was fentanyl at 64%. So nearly 2/3 of all of the overdose deaths in the state of Indiana contain the same substance, and that is fentanyl. The next most prevalent substance is methamphetamine, followed by benzodiazepines and prescription opioids. You can see alcohol and antidepressants at 22%, cocaine at 22%, and then heroin at 20%. I'll also remind everybody these are not mutually exclusive. So individuals often die with many substances in their system. So this is just the prevalence of those, the detection of those substances within these deaths. So you can see here we've created these figures. Again, we're really focusing on getting this information actionable back to the county. So what we've done is create a ratio of how many of the overdose deaths in that county had that particular substance present. So the darker it is, the more frequent that substance was detected in overdose deaths in that county. Again, not adjusting for population. And so you can see on the left there, fentanyl, where it's a darker red, there's a higher proportion of the deaths had fentanyl. In the middle, we look at heroin, followed by prescription opioids on the right there. Keeping in mind that there could be 2 deaths in a county, and both of them had prescription opioids, and so it would be 100% in that particular county. We've also done the same thing looking at cocaine and methamphetamine that you can see here as well, where those are showing up in these toxicology results. So where are we in particular with undercounting? What we found is that statewide, only 6% of the cases were coded as unspecified, down from approximately half in 2017. So this is really a remarkable achievement. Of those few that are coded as unspecified, they do have that T50.9, which is an unspecified drug, but looking at the toxicology results, we can see that all of them actually had fentanyl present. So guidelines indicate that they should have used this T40.4 to indicate fentanyl as present in those deaths. Finally, I just want to say with the toxicology results, we're also able to look at the impact of COVID on the overdose epidemic. So we focus here just specifically on Marion County, and what you can see is that this shows the time period following COVID-19 stay-at-home orders and the time period prior to that. And then we've put these lines to illustrate 2020, 2019, and 2018. So you can see the deaths are much higher in 2020 than they were in 2019 or 2018 in this time period. And that there was, in particular, and we found this in other states that we've looked at, a spike about 1 month out where individuals had a very high rate of death in Marion County. And we have looked at the specific substances that are detected in these overdose deaths. And as you can see there, all substances have decreased: heroin, prescription opioids, cocaine, methamphetamine, and benzodiazepines in their detection. The one substance that has increased is fentanyl. Fentanyl was detected in 93.1% of all of the accidental overdose deaths in Marion County following the stay-at-home orders for about 180 days after the stay-at-home orders. Here's a link to the report at the top for those of you that can want to look further at the reporting that we've done to the website. Please, I apologize that I was not able to be there in person, but please do not hesitate to contact myself or my team, and we'll get back to you with questions that you might have on this analysis. Thank you.
Well, great. Thank you. I want to thank Dr. Ray and his team for the work that they've been doing. While Dr. Ray was not able to join us today, we do have members of his team on the call who have joined us. Are there any members of the commission who have questions for Dr. Ray's team or Katie regarding the presentations we just saw? If you will maybe wave at us, we can get you unmuted if there are questions. Anybody? Okay, well, seeing none, let's thank you, Katie. Next on our agenda is Rebecca Buhner. Becky is the Deputy Director for Addiction and Forensic Treatment and the State Opioid Treatment Authority at the Indiana Division of Mental Health and Addiction.
Good morning, Commission members, and thank you, Mr. Huntsinger, for the opportunity to speak today. As he said, my name is Becky Buhner, and I'm the Deputy Director for Addiction and Forensic Treatment at the Division of Mental Health and Addiction. So I'm going to take the opportunity today to talk through a couple of the grant awards that we have received and some of the initiatives that we're working on. So most recently, DMHA was awarded the Comprehensive Opiate, Stimulant, and Substance Abuse Site-Based Program, otherwise known as COSAP, and this is through the Bureau of Justice Administration. We received just under $6 million, and as you can see, this grant just started in October, and we are awarded under Category 2, which the objective of Category 2 is to support states in their efforts to implement or enhance in a minimum of 6 geographically diverse counties, localities, or regions, activities that will expand access to supervision, treatment, and recovery support services across the criminal justice system, support law enforcement and other first responder diversion programs for nonviolent drug offenders, promote education and prevention activities, and address the needs of children impacted by substance abuse. As you can see, we have identified Allen, Clark, Fayette, Floyd, Knox, Madison, and Wayne counties. And each county worked together with our team at DMHA to develop a budget and a plan. And they each received just around $245,000 per year. And as you can see, this will be a 3-year grant. So I know I have spoken with you before about our state opioid response grant, and we were just awarded another cycle of this grant. And as you can see, that is just under $60 million for the total grant award. The budget cycle, we just have 1 year awarded, which is just under $30 million. And we, just kind of a point of reference for our team, under the first state opioid response grant, we actually wrote and oversaw just over 80 contracts for that grant and around 6 memorandums of understanding. So there's a lot of work happening with our team. And some of those initiatives in that first grant, we are continuing through this next opportunity. That is to expand and fund recovery residences. So far in our pilot project, we have just over 102 clients and 14 recovery residences that are involved. And we've paid out claims of just over $220,000 since January. As Mr. Hunsinger mentioned earlier, we are working to expand medication for opiate use disorder in jails as well as in the communities. And this initiative really got going around March of 2020. And so far, we've had over 100 clients total between our jail and our community-based project, and just over $300,000 in claims paid out. We're doing a lot around evidence-based practices and workforce training, and I'm going to go into 2 of those projects here in just a minute. We're continuing our mobile response systems, which are in at least 8 counties, where they're really going out into the community and meeting folks where they are and what they need. We have alternative peer groups, where we have in the past partnered with Hope Academy, and now we are expanding to move into Howard County for a second alternative peer group. I hope you have heard about our regional recovery hubs. We've had a press release on this and a lot of information going out. And this is an opportunity in different areas of our state. We have several communities that are partnered, and this is through Mental Health America of Indiana and Indiana Addictions Issues Coalition and the Indiana Recovery Network. And so it's a strong partnership where we are working to build recovery community organizations and utilizing peer support services as an opportunity to engage folks at different levels of their recovery and their treatment. So they're going to be partnering with opioid treatment programs, with Department of Corrections, with local jails, as well as just with community groups. We're continuing our sequential intercept model, which is a partnership with Indiana Office of Court Services. And this is an opportunity for every county to get up to $60,000 a year for 2 years to implement one level or one of the intercepts along this sequential intercept model. And then I want to call your attention to us updating our strategic plan. This is a project that we started when Mr. McClellan was here, and through our state targeted response grant. And with the opportunity of the new funding and the additional support for addressing stimulants, not just opiates, we're going to be updating our strategic plan. So I would expect for you all to hear from us relatively soon in the next couple of months about participating in this process, because again, we do believe that this is a community process. And so as I mentioned, there's a couple of evidence-based practices I want to talk about today. And the first one is CRAFT. And this is a community support, or I'm sorry, a family support group. It's the Community Reinforcement and Family Training. And this is a partnership with Overdose Lifeline. So CRAFT itself is a highly effective evidence-based approach for working with family members trying to cope with a loved one who is reluctant or refusing to get help for a substance use disorder. It's a 12-week program that includes group education as well as a support model. And they utilize a book authored by Dr. Robert Myers, Get Your Loved One Sober. And it involves just participants attending weekly sessions at no cost to them, where they review the books and they have workbooks, and they also do weekly lessons, and they have homework sessions and group sharing. And they really teach effective strategies for self-care. And because Overdose Lifeline is such a strong partner with naloxone, they are also including naloxone training and overdose reversal kits for folks that are included in this. As far as implementation in Indiana, we have trained a total of 52 new facilitators through 4 different trainings. And this has been covering 25 cities and 15 counties. And you can see some of those labeled, or I'm sorry, some of those mentioned there. CRAFT as a session, they average around 9.6 out of 12 that are attending the sessions. And 100% of the respondents claimed that they were using the communication skills learned through craft. One of the respondents indicated their loved one had started treatment since beginning craft, and all of the respondents indicate they agree that they know how to improve their family's well-being. 80% of the respondents indicate the skills learned in craft were extremely valuable. Our next steps for craft are to train an additional 40 craft facilitators and focus really on underserved areas in Indiana. I just want to make a note that along with everything else, as a result of COVID, we have gone to virtual groups and meetings for this opportunity. The next one that I want to talk about is Preventure. Preventure is a personality-targeted, selective evidence-based practice. It's an evidence-based program which takes personality-targeted approach to adolescent substance use prevention. The program content was developed to target personality types found to be at highest risk for substance misuse. So they use the Substance Use Risk Profile Scale, and then they have they do the assessment, and then for youth or students who have high SERPs indicators on that scale through the 4 personality types, they participate in 2 90-minute workshops to address their challenges. So I just want to make a note of some of the results and the statistics from this project. What they're showing, and this is international statistics. They reduced drinking rates by 40 to 60%, binge drinking rates and alcohol use by 50%. They've delayed onset of drinking and binge drinking. They've reduced illicit drug use rates by 30 to 80%, and reduced risk for alcohol-related problems, as well as other mental health problems such as anxiety, depression, and conduct. So since June of 2020, we have been able to conduct 5 separate virtual trainings to a total of 38 individuals who have received this certification. As we move forward with the next steps, we plan to train an additional 50 Preventure facilitators across the state, again, focusing on rural areas of our state and areas identified as high need. And we will continue to offer these through virtual opportunities and continue to provide technical assistance. At the last commission meeting, Dr. Sullivan shared with you some of our efforts around the Indiana Crisis Counseling and Assistance and Training Program. And so I just want to quickly provide you with an update. This is a grant that started through FEMA and has carried on through SAMHSA, and it's totaling just over $4.8 million. It started in April, and it runs through June 27th of 2021. This is a very targeted time frame based on FEMA and their availability of the funds in a response to a crisis situation. So we have fielded over 3,500 calls and spent about 1,000 hours of crisis counseling. And I just want to note that these stats are as of November 4th, and since that time we've fielded an additional 300 calls. And part of that call volume going up is hopefully you're starting to see our commercials. We just relaunched our media campaign around this effort. Just over 1% of those calls are critical in nature, and so what that tells us is that the project itself is working. The goal of this project is really to be available for folks that have concerns or questions or going through difficult times related to COVID. And so the idea is to get those folks before they become that critical call. And so when we look at this statistic, we say, okay, this shows that it's working. And the other thing that the team is able to do is they're able to respond and provide psychological first aid groups and debriefing sessions for smaller communities. So we did have one community reach out to us who was within their court systems, having some challenges related to COVID. So our team was able to reach out to them and provide some support and some assistance so that their staff would have somebody to talk to. So Mr. Huntsinger mentioned this in his open remarks, and so I just want to call your attention and provide you a little bit of an update. There was a recent press release on this. I would encourage you to check that out. Director Chaudhry at DMHA has really made the incompetent to stand trial a priority for him and for our team. And so we started looking at the jail-based and community-based community restoration project. And right now we are in Marion County and Vandenberg counties. Vandenberg County is partnered with Southwestern Behavioral Healthcare. They have started this initiative and they have served one individual thus far. Marion County is just getting ready to get started. Most of the work that we've done has been through training and education, not only for the jail staff, but also for local partners about what this initiative will look like. And I have to say that this would not be possible without the strong partnerships that we have at the local levels. And I do apologize, judges are not on that list, and they should be, because they are truly one of the biggest partners we've had with this project. And the intent of this project is to allow folks who are deemed incompetent to stand trial to start receiving services that they need related to their serious and persistent mental health around treatment, assessment, medication. And medication, depending on the need, can reach up to $1,200 a month. So it's a very costly project at times. But what we were able to tap into some of our block grant funding, and it's just over $1 million for this pilot project now. And the goal will be to get folks to have their competency restored while either in the jail and or in the community, so that they don't have to go on that wait list for the state psychiatric hospital, and they can actually start their trial earlier. So I'd like to just touch base on our opioid treatment programs. As we all know, this has been a strong initiative of this administration to expand our access to our opioid treatment programs, and I'm happy to say to you that we are doing that. So this data is based on the 21 opioid treatment programs that serve patients during state fiscal year 2020. And so we did have one new one open in the midst of COVID, LaPorte, so we thank them for all their efforts around that. And then we had 2 open since that time. Knox County opened in May and Hendricks County opened in October. So those 2 are not included in this data set. So we are seeing on average around 14,000 folks, and this number has been consistent if you look back 5 years. In 2019, we had just around 11,000, which was a little bit lower than what we had expected and what we had seen in the past. But overall, we are seeing anywhere from 14 to 16,000 folks in our OTPs per year. Just under 7,000 of those individuals are females, and then 52% are males. So it's really a pretty even mix in many ways. We had 12% of the women that are pregnant that were served at our OTPs. And then as you know, and as I've talked about before, Medicaid started covering this service in September of 2017. And since that time, we've had 37% of the individuals covered through Medicaid. And so that number prior to 2017 was 0. And so again, this is a huge initiative on our administration's part, and we're very proud to say that folks are getting access to treatment and funded through Medicaid to support their recovery. And just over 6,000 individuals were able to eliminate use of illicit substances after 1 year of treatment. So for those of you that are visual, here is a map that shows you where all of our opioid treatment programs are currently placed. And we have 5 more licenses that will be awarded within the next 12 months. And so I would watch for that opportunity to be released here shortly. So with our Recovery Works program, I wanted to quickly touch base on our numbers. And as you will see on this slide, if you look at the amount of dollars spent, we were on a steady incline through 2018. And for those of you that were with us at that time, you know that we had to do some reduction in the availability of services to make sure we maintained our budget. And then in 2019, we were right at 20 million, which was right on target for our budget at that time. But one of the things that we did in 2019, towards the end of that state fiscal year, so as of July 1 of 2019, we required that all of our providers through Recovery Works be able to bill Medicaid for access to treatment services. And what this meant is that more of those services were being funded through Medicaid. And so that is one of the biggest reasons you'll see that drastic reduction in the amount spent for state fiscal year 20. Of course, like everything else, COVID does affect that number a little bit. As you can see from our enrollments, those were down. But what this has allowed us the opportunity to do is to make some changes with COVID and allow for some other funding opportunities. One of those is that we included a discretionary fund, which is a limit of $250 for a lifetime for an individual, but it allows for funding to pay for phone cards, to access cell phones. One of the things that we did through COVID is we followed along with Medicaid's lead on offering telemedicine for individuals involved with Recovery Works. And so getting those phone cards so folks could continue to participate in treatment was very important. The other thing is accessing birth certificates and driver's licenses. This was something that we didn't necessarily have the funding to support in the past. And so we are able to offer the discretionary fund so they can do that, as well as any services with getting IDs or anything like that. So effective January 1st, there'll be a 50-month limit on the discretionary fund, but a total lifetime of $250. The other thing that we were able to do through COVID that was very helpful was extend the number of days that a person had access to recovery residence. And so what we know is that if folks don't have a safe place to live, they're not able to maintain their recovery journey as easily as when they do. And so we wanted to extend the opportunity and allow for more days of recovery residence through COVID especially, and then also to continue that on, knowing that when people have access to that, their recovery is more stable. The other piece that we are going to be adding starting December is the legislature allowed for us to start a misdemeanor pilot with the approval of JRAC. We did have that approval a while back. However, with our funding and our budget, we were very limited in moving forward with that pilot. And so because of the hard work of our team and our providers, we would not be in the place we are if our providers were not as successful with becoming Medicaid and working so hard as they did. So we're going to be starting a misdemeanor pilot December 1st, and we will have more details released on that very soon. The Recovery Works team is putting out that information today and tomorrow. And then we will be releasing just an email note to let folks know there will be an opportunity. It will be an application process for communities and criminal justice partners to get involved in this pilot. And so that information will be coming out. And we are looking to include a set amount of funds for treatment services, just around $1,500, because we know that folks will need access to some funds, but most individuals that are tried for a misdemeanor would still have access to some form of insurance or Medicaid. But then also the access to housing assistance, so they will have access to $2,500 for housing assistance. So with that, I would like to reintroduce to you Brad Ray to talk through our evaluation.
Hi, this is Dr. Ray again. This time I'm going to be talking about the DMHA Recovery Works program. Again, just to put this statewide initiative into a national context, we have long known that persons with serious mental illness or substance use disorder are more likely and disproportionately represented in our criminal legal systems. So you can see on the left-hand side there, persons who are in jail are 8 times more likely to have a substance use disorder. On the right-hand side, you can see rates of serious mental illness are 5 times higher in jail populations, much higher for women than men. We also know that these individuals are more likely to cycle back through these systems. So you can see here about more than half of those with a substance use disorder who were incarcerated had been in that facility 2 or more times in the past 12 months. Similarly, you can see if you look at the percent with serious or moderate mental illness, less than 10% had not been there in the past 12 months. And I've also put the percent with health insurance to illustrate that as well, as that many of those without health insurance repeatedly cycle back through these systems as well. Recovery Works is one of the ways that Indiana is trying to address this social problem. So for those of you that might not know much about Recovery Works, I'll just briefly tell you it started in late 2015. It replaced an earlier program called Access to Recovery. It was a federal voucher program from SAMHSA. And it's designed to provide support services to those without insurance who have a mental health or substance use disorder and have entered the justice system. This was Recovery Works was funded as part of the Indiana Justice Reinvestment Initiative. So it's a voucher-based reimbursement program that offers specialized services, and the hopes is that by increasing access to treatment and wraparound services for those with mental health and substance use disorders, that it can reduce involvement in subsequent involvement in the criminal justice system. In our prior work evaluating the Recovery Works program, we've looked at things like client characteristics, and we've also looked at changes in the treatment episode of care. So as you can see here, demographically, clients are by and large white males, average age of 35 years old. The population has a lot of potential risk factors for continued criminal justice involvement. For example, nearly 30% have not completed high school, nearly half are unemployed and looking for work. At Recovery Works start, more than half did not have any insurance, but also keep in mind many of these individuals have, or all of these individuals have a serious mental illness or a substance use disorder to be in the program. We've also looked at changes during a treatment episode of care. So we've looked at folks who started the Recovery Works program and then continued in the program for at least 6 months to see what the follow-up was. We did this for over 4,000 clients, and what we found was increases in employment and housing stability and independent living, and decreases in self-reported crime and drug use. However, one of our key goals has been to look at recidivism back into the criminal justice system, with the ultimate goal of examining the potential cost savings to criminal legal systems from Recovery Works. One thing that many people don't often consider, though, is the difference between jails and prisons. So jail is really the entry point to the criminal justice system. To illustrate this, about 6,000 people enter prison, 600,000 people enter prison every year in the U.S., but about 11 million people enter into jails. This is because people who are incarcerated in jails are incarcerated for shorter periods of time, but also many of those who go to jail do not go on to prison. So in prior years, when we've tried to look at this question of recidivism, we've only had state prison data. So we'd be looking to see whether or not Recovery Works clients went to prison. But to answer the question of who went back to prison, what we discovered is that many of the Recovery Works clients, the majority, have never been to the Department of Corrections. And this is because someone is eligible for the Recovery Works who has a felony charge, not necessarily a felony conviction. So people who had a charge reduced, dismissed, dropped, or disposed of in any way, a felony charge, would still be eligible for Recovery Works. So in this past year, we've developed this partnership with the Indiana Management Performance Hub, and we've been able to integrate state police data as well as prison data to get a more nuanced understanding of the criminal justice involvement of individuals who are in the Recovery Works program. And it's really important to get this to get a more sensitive measure of recidivism. And individuals are much more likely to go back to jail again than they are prison. And it's also difficult without sentencing data to determine, create a comparison group. So what we're doing is using individuals as their own comparison with the amount of time that we have available now. So we're looking at folks 3 years before Recovery Works and then 3 years after Recovery Works across these 3 different events: arrest from the Indiana State Police arrest data, CRIS data, prison incarceration events from the DOC, and then we combine these to look at any incarceration events or any criminal justice events. Some of the preliminary results from these efforts I'm showing here, we've looked at those who enrolled in the program during the 2016, so we can look at the 3 years before and after. So we're looking at 20,000 or so individuals here. On the left-hand side, you can see the average number of prison events before and after Recovery Works declined, and the prevalence decreased from 14.3% to 8.6% after Recovery Works, for about a 5% reduction in the prevalence of prison incarceration. When we look at the arrest, keeping in mind it's a much more likely to occur, we see the number of arrests, the frequency of them, reduced from 4.6 to 3.4. The prevalence reduced almost 10%, from 40 to 30%, and the prevalence of jail post-Recovery Works. Finally, when we combine these measures together, we found about a 7.7% reduction in any criminal justice involvement or incarceration before and after recovery works. We've only recently been able to integrate all these data elements for analysis, but as you can see, our preliminary results suggest the potential for long-term decreases in criminal justice involvement following entry into recovery works. This impact is really pronounced at the county level with a near 10% reduction. And while we've not yet calculated the cost specific to Indiana, estimates suggest that every dollar spent on non-prison treatment services can save almost $9 and reduce incarceration time. So if we were to use this formula, Recovery Works could expect, $80 to $140 million savings per year. But with these new jail data, we're helping to more precisely measure the impact in Indiana, the potential savings there from reduced criminal justice involvement. Additionally, one of the other things that we're hoping to look for folks that might not know, overdose is actually the leading cause of death for returning inmates. And so we want to look at whether or not involvement in recovery works had any impact on emergency medical utilization or overdose. But also housing stability has become a major part of the Recovery Works program. And so we want to look at individuals who have been able to have a stable housing situation and how that has impacted their Recovery Works outcomes. Again, there's some links to some of these reports that we've done in the DMHA Recovery Works website. And by all means, don't hesitate to contact us with any questions that you might have about our evaluation of this program. Thank you.
Thank you. Are there, this is such great data. Are there questions for Becky or for Dr. Ray's team who are on the call? Okay. Well, I want to thank all our presenters for sharing, such valuable data and information with the Commission this morning. All of today's presentations will be available on our website. I'll just make a few closing remarks in that it's really evident, I think, from the presentations today that, our administration is not sat by and watched the side effects of COVID-19, but rather we've taken a proactive approach. And if anything, COVID-19 has us working harder than ever and in more collaborative ways to help those with substance use disorder and mental health challenges. As we look ahead to 2021, we'll remain committed to ensuring individuals the quality, care, and treatment they need and deserve to enter recovery from any substance use disorder. I thank all of you for your partnership and all that you do to make our state a better place for all Hoosiers. I appreciate everyone's time and attention today. And as a reminder, our next meeting is February 5th at 10 a.m. in a format that has yet to be determined. So I thank you all for your time, and we stand adjourned.